love to invite Kara and Vinu back. We already have a couple in the Q&A, but let's keep those questions coming. I want to try in the brief time we have to kind of encapsulate a few of the themes that I heard from each of you. And because I like alliteration, I want to talk about patients, and you all talked about sort of engaging patients and communities. There's of course a lot of conversation about the workforce and providers, although I personally don't like the term providers, but healthcare professionals, the healthcare professional workforce, the payer landscape, and then I want to talk about accountability and results. Again, I encourage folks to share their thoughts in the Q&A. But let me start. Let's start with the people, the people, the patients, their caregivers. You know, each of you mentioned this, you know, in terms of co-designing the technology. Kara, you used a phrase that I just love, this engaging communities in humble inquiry, and really having a strength-based approach. People know what they need. Esther, of course, you talked about it, really engaging and earning the trust and helping to guide people through what can be a really complicated process. So I'm wondering if each of you can give a little bit more depth into those thoughts, like specifically beyond stating those as a goal, like what are the tangible things that need to happen to make that a reality from each of your perspectives. And Vinu, maybe I'll ask you to start from your perspective, just tangibly, how do we truly engage people in this process?
Yeah, I mean, I did refer to the concept of co-design, and I think primarily that's been the lens I've been doing my work for many, many years. And I think, you know, over the years, we've gotten more sophisticated from like, okay, let's survey people, to doing focus groups, to having an advisory board. But I think the way that we're really going to shift things is if we involve our patients and consumers and community members in, you know, identifying the problems, you know, developing solutions together, giving feedback along the way. So I think there's more and more work around this, like taking this human-centered approach and making sure that we're hearing the voices from a diverse community. So my sense is we have to really start moving to truly co-designing solutions with people.
Thanks. Kara, what are your thoughts?
I would agree with Vinu, and I think that one of the things that we often find is that people, organizations, businesses, communities are sometimes afraid to engage. I shouldn't say afraid. They don't necessarily want to engage community because they feel like community might be nervous, anxious, might not want to participate. And I think that those are sort of fallacies that we need to kind of work beyond. And some of the work that we saw when I was at CMS and sort of engaging with beneficiaries, that we can present information and get their opinions and really bring them into conversation in a way that does lead to very productive and helpful conversations. So I would encourage sort of each person on this call to think about, you know, how are you developing your programs, policies, solutions? Where are there opportunities to solicit that feedback? And part of that is also building that trust in community. So that takes time. And there are some organizations who have spent, you know, one of the ones I think about, the California Endowment, spent like a decade building trust in communities and engaging people to have that capacity to be ready to address some of the issues. So working with some of those trusted voices in community to build that relationship is a way to bring those voices into organizations that may not have traditionally had that input in the past.
Thank you so much. Esther, what are your thoughts from the research perspective?
I would echo the comments that Vinu and Karen made, which is very consistent on the biomedical research ecosystem front. We talk a lot about engaging patients in medical research, right? Patients understand their lived experience. They understand what's important to them. They understand what kinds of studies we ought to conduct, what kind of endpoints we ought to look at when we're looking at a drug or a therapeutic in terms of improving their quality of life. We have data to contribute as well in terms of their own day-to-day experiences. And that data can be aggregated, can be collected, can be used for various purposes. The challenge is that patients are often not asked Their opinions are not asked to be part of that co-design process until the very end. And what ends up happening, particularly in clinical trials, we say, well, we're not enrolling adequate numbers. Why don't we have patients who are traveling 2 hours to a site, for example, and why are they not following up on studies? Or the trial investigator might just say certain kinds of patients may not be good for this trial because they can't do all of these various things. However, if they're brought in at the beginning to help to design a clinical trial protocol, what we find is that those enrollment numbers are higher and the participation is longer and more sustained. And then of course we get better information, better evidence, better data in terms of the efficacy or safety of a particular therapeutic that really are meeting the needs of the patients.
Thanks. And I think Esther, I think it was you who had mentioned, institutional review boards. I mean, is there like, who is accountable, who can be accountable for actually doing that work? Is that something the IRBs can do? Like, who should be charged with that?
Everyone can do that work. So whether you're a sponsor of a clinical trial, and typically we have a variety of different kinds of organizations and sponsors of clinical trials. This can be biopharma. Quite often in biopharma, what we see is they create these patient advisory boards. Again, these are very forward-thinking biopharma companies that understand the value proposition that I just laid out, but there is no requirement that they need to do that across the board. We obviously have the NIH-funded studies that happen in academic settings. There is an encouragement to engage the community, but not necessarily a requirement and accountability to come back and make sure that what was put into that grant application actually happened and those targets were actually achieved. And then of course there is the role of FDA as a regulatory body to say, if we're asking for data on diversity, what do we do when a company does not provide that data? Are there penalties, which of course FDA has veered from doing, but can we make sure that we have both the carrots and the sticks from that perspective?
Thanks, that's really helpful. So there's been a question in the queue about workforce, and I want to really ask that. And the question around the workforce needed to get poor communities to understand technology, to maintain engaged in using technology. And so I think this came kind of after your presentation, Vinu. Like, is there a role for the healthcare workforce in kind of helping folks to use the new technologies? What will the impact on the workforce be? And then I want to ask more broadly about workforce to Esther and Kara as well.
Yeah, I definitely do think there's an opportunity there. I think for too long, we haven't taken that role as a specific role to help support people and finding ways for people to actually work on it. It's been sort of this afterthought if you're an MA or whoever does it. It's been interesting during the virtual care world that we're living in, this new role of a telehealth support specialist has kind of emerged. And I think there's some interesting opportunities to leverage young people. We have a program now that we've been running where there's pre-med students and students who are extremely tech savvy, who need minimal training getting up on technology, who are now doing outreach to people in health centers and public hospitals and helping them get set up on video. And we're also starting to see people creating, I've been doing work with an organization called Futuro Health, who's creating workforce needs for the future and realizing that this role of a telehealth support specialist is something that's going to be important. It may be video in the future. It might be helping getting people on remote patient monitoring and understanding the technology. It may be getting people on patient portals. But I think starting to think more about how you actually build workforce, whether it's the future student workforce or a carved out role, I think is going to be important because I don't see that role going away. It may just evolve over time.
Thanks. That's super helpful and interesting, and maybe some new opportunities there. Esther, you mentioned community health workers and that role, and Kara, I know you've also written extensively on the healthcare workforce, and just I mean, and right, like we all have to acknowledge, of course, the incredible strain on the workforce that COVID has presented with the burnout and all of the challenges therein. I'm wondering if either of you would like to jump in with any additional thoughts about what tangibly can we do to help the workforce in terms of health equity goals?
I'll be brief and then turn it over to Kara. I'm quite interested in what she has to say here as well. I think we need to think about the workforce as both the traditional workforce and the non-traditional workforce. And from the non-traditional workforce perspective, I did talk about community health workers, for example, or nurse navigators as yet another example, but also the role of pharmacists. Increasingly we see retail organizations that are interested in leveraging their retail sites, which are closer to the community because they're used for a variety of different purposes, serving as clinical trial enrollment centers, for example. Pharmacists have a unique opportunity to educate patients as they're coming in to receive their medication, their prescriptions, to say, hey, but by the way, you may be eligible for such and such a trial. So thinking outside of our traditional box of the primary investigator, the research coordinator, but also looking within the community for other types of workforce.
I think that's a great point. And I think just building on some of the comments that Vinu made as well about the technology space, I think it's also important that we recognize there are still some technology barriers that we also need to deal with. And that's part of what's contributing to some of the technology gap that we have. So when you look at households that are led by someone with a high school education or less, they are less likely to just have internet. So that's a basic thing that we're thinking about, plus not to, the cost of internet into homes. And we've seen a lot of that technology sort of helping in this moment as we've had kids working, doing school from home and people working from home, that some of the communications firms have stepped up to try and help people get access to technology, but that still is a bit of a challenge. And when we think about the way that apps are moving and technology there to be able to look at health, that is still, $400 for an Apple Watch or more is sometimes a little cost prohibitive for some people. So we need to think about how do we make technology more accessible for those at the other end of the income spectrum so that we have that ability. In terms of the workforce overall, I think that, Esther's comment about thinking about traditional and non-traditional is so important, because we also need to think about how we receive care and how we want to receive care is changing. No longer are we all sort of thinking about this, box where you have a hospital or you have, just the firm doctor's office. We're getting technology, we're getting people into community to receive those services. And I think that that's only going to continue to change. And so we need to look at our health system, look at our payment to think about how is it really sort of meeting people where they are and where they want to receive care, and allowing for that flexibility to provide those services in a way that is most convenient to the patient. And I think the last thing I would say when we think about the workforce, I continue to be rather vexed that in this moment where every day there is an article about the provider burnout, about the health professional burnout, where public health people who are quitting, retirements that are happening, traveling nurses that are eating up resources and depleting in communities, that we are not having a national dialogue on the healthcare workforce, that we need to be thinking about how are we planning for, paying for, and getting the workforce that people need and engaging people, because we can't keep asking the same few doctors, nurses, or whomever to be doing more and more. We need to think about really our care teams and health teams that include public health, community health workers, and others, to make sure that we are addressing people's holistic needs, and to make sure that health, public health, social services, and human services are also linked up so that it is kind of a one-stop shop.
Thank you so much for that. And I want to acknowledge that there are a few questions in the queue and we only have a few minutes left. And so I'm going to be, I guess, as democratic as I can and pick the one with the most thumbs up for this one. But thank you all for your questions. And of course, to acknowledge that in the words of the late Paul Farmer, it is very expensive to give bad medical care. Yes, it is very expensive to give bad medical care to poor people in a rich country. Quotes our questioner. Our road to equity of care continues to be diverse, challenging. What specific systems change do you think is going to be the most financially effective and clinically impactful? Kara, you just mentioned workforce, and the need for national strategic plan. Is there anything else that you would like to add to that systems change question?
Yeah, I think, you're seeing it, and you heard it in Dr. Seshmani's comments about that, the value-based care. we have, in Medicare specifically, a system that is set up to do fee for service. So how do we think about really making those changes to allow value-based care? We've also talked about, and as Esther mentioned, community health workers, the definition of the essential, eligible provider that we have and who's eligible to receive payment is something that's a little bit antiquated given the way that we're providing care in communities, and need to think about how that also changes. So those are a couple of the things that I would suggest. And then I think one of the other pieces, we haven't really talked a lot about Medicaid today, but Medicaid is a critically important program for so many low income and pregnant women and children in our communities. And that is a state-based program, but it is also a program that prides itself on being extremely effective and efficient with the few dollars that it receives, and thinking about how we're allocating those resources to help think about the care that people need longer term and the health things that they need to be able to stay healthy and actually move to prevention rather than treatment.
Thank you. Vinu, your thoughts?
I think Kara summarized my thoughts. I had listed down, and they're all of them, which is value-based care, changing the payment models, focusing on prevention. And I think the other thing is just figuring out how to more effectively use technology in a way that's equitable.
Great, thank you so much. And Esther, your thoughts on the systemic change that's needed?
One of the ideas that comes to mind is the recovery trial in the UK for those who followed clinical trials for COVID-19, a pretty famous trial where what the ideal that we've been looking for, linking clinical care and clinical trials, occurred in that setting. That would be fairly transformational for us to have large, simple trials that are embedded in clinical workflows where a doctor can very easily say, is this patient eligible for a clinical trial while they're getting their clinical care at a low cost, and we're collecting the right amount of information without overburdening the entire system. Would be amazing.
Great. Well, thank you. Thank you all for your thoughts today, for your presentations, and for being part of today's panel on delivery system transformation towards health equity. I want to again thank Esther Profa, Vinu Alek, and Kara James for your time today and really, really deep insights. Want to again thank all of our participants for being with us this morning on what is certainly a very challenging day in the world, and we thank you for being here and for your attention and engagement. We look forward to seeing you tomorrow at 9 a.m. Pacific, noon Eastern, for the Changing Business of Healthcare session, which will be day 3 of this Healthcare Forecast Conference. Finally, you will get your CME survey on Friday. You'll get the links to all of the presentations, and certainly, can I have them connect with us on LinkedIn? Everyone's on LinkedIn, right? Y'all can find us there. Thank you so much, everybody. Have a peaceful afternoon.